All right, guys, we're going to go into myth number one, which is that there's one specific exercise for sciatica. So if I'm sure a lot of people pay a visit to Dr. Google before they come in and see me or see the other physical therapists or chiropractors, and you get 8 million results for exercises for sciatica. And the reason for that is a lot of the research now shows that there's not one specific exercise or really specific low back exercises are better than just general physical activity. That's not saying the exercise you're doing with your patients or exercise you find on the internet are always terrible. They're not good. But the research also shows that if you're just more consistent with with one or two exercises for your sciatica pain, that you're going to get better results from that than trying to do 6 different exercises all the time. So just kind of focus on one. There's not just one best exercise for a sciatica. I have ones that do in my office that I really like, that I see results with patients. But that's myth number one, that there's not just one best exercise for sciatica. Guys, so myth number two is that rest will not get you better. So obviously we don't want to confuse radicular pain with non-specific low back pain. So acute radicular pain or sciatica is that, severe pain in the glute that will travel down the leg or in the back that travels down the leg. Non-specific low back pain does respond really well to movement, and sometimes sciatica does too. But we have to be careful of not, knowing when to rest our patients, and you guys knowing when to rest versus when to move and to kind of push yourself. So I had a patient a few weeks ago. This is a great example. Came in, 8 to 10 out of 10 pain when he was in here, sweating, in tears, stressed, frustrated, just in a lot of pain. And so for him, am I going to try to adjust him and get him to move a bunch while he's in here? Probably not. A lot of times I told that guy, hey man, you potentially need to go either get an MRI or something like that, imaging, but most of all, you need to just rest. You need to take it easy as much as you can. Some people, that stresses some people out, but we don't want to make patients feel guilty for taking necessary steps to get better. And sometimes that is rest. And we have to be, there's a lot of wisdom in knowing when to rest yourself, but also as a clinician and talking to other clinicians, knowing when to rest your patients. And a lot of people come in with non-sciatica issues, like shoulder pain. There is a time where something bothers it and you want to keep doing it. Well, maybe for right now, let's rest that for a couple weeks and get you better, do the rehab, and then get you back to doing those things. Same thing with sciatica. If a person's in a lot of pain, movement may not be the best medicine for them at the time. Rest might be the best option for them. So that's myth number two, that, if you don't move, you're not doing something, then it's not going to get any better. Third myth is that saying that you will 100% get better with radicular pain. So unfortunately, there's a subset of people, about 1/3 of the population who has radicular pain, will experience pain from anywhere, and it could be severe pain, it could be mild pain, from 1 to 4 years experience that pain. So if you're a physical therapist or a chiropractor and you're telling patients that you're 100% going to make a recovery, that would be a myth, that would be a lie. And it's honestly more ethical just to set expectations to people. It's like, hey, I've seen this a lot, and the care that I provide does work really well for this, and it can help you in a significant less amount of time than if you just didn't do anything or whatever it may be. But to say they're going to 100% make a recovery when they come in, it would be a myth. It would be non-ethical to do that. And again, there's that one, they could be part of that 1/3 that has that persistent pain for 1 to 4 years. So just to set expectations doesn't mean that working with you is a waste of time, because now they've learned stuff that they wouldn't, know before. And then from the patient's point of view, just knowing that when you come in, knowing that if you can make better progress over that 1 to 4 years and maybe reduce the amount of pain, but doesn't mean your pain's going to go away 100%. So it's not saying if you come in with severe pain that you're going to have that severe pain for 1 to 4 years. It just says that there's a population that could have severe pain for 1 to 4 years, or you could have, reduce that pain, but still have pain from that 1 to 4 year mark. And that's roughly about 1/3 of the people that deal with radicular pain. So obviously when patients come in, still want to provide, hope, compassionate, empathizing care and hopeful care, but, not, really not trying to be exceeding expectations and stuff like that in terms of what you tell them. Obviously you want to exceed expectations when you're treating them, but you don't want to be getting them too hopeful about what's going to happen, which sounds weird, but that is, probably the most ethical thing to do, is never guaranteeing that, hey, you're going to 100% make a recovery. So that's myth number 3, is that this will always get, just 100%. Fourth myth of sciatica is surgery is never needed. this is definitely a myth, and I've had certain patients that I've sent in, to get MRIs and potentially surgery. So I'm not opposed to surgery. I think it's overdone a lot of the times. It doesn't always necessary, but it doesn't mean it's never needed. There are some patients who, experience significant strength loss and sensory loss and nerve function loss due to radicular pain. And in those circumstances, you have to be, just very wise and cognizant and, think critically about what's kind of going on. And a lot of times the systematic review came out showing that surgery intervention for that 3 to 6 month mark can drastically reduce pain. So it's more of a short-term relief of pain, and then long-term, conservative management, chiropractor, physical therapy, actually has a pretty much similar outcome to surgery in the long term. So obviously, that's a discussion you have with your patient, or if you're a patient, that's a discussion you have with your physical therapist or chiropractor is, hey, you watched this video and or I'll have the studies also posted, but is surgery, do you want to get out of pain in that 3 to 6 months? You want to get out of pain quicker, but have similar long-term results with conservative management, or do you want to take the time, with chiropractic and physical therapy and just kind of endure a little more pain, but still have the long-term outcome? Obviously, sometimes the two combined can be good. Sometimes surgery, again, is not for everybody, but does not mean it's never needed. There are some circumstances, which I've had patients in here who I believe have needed surgery, because like that guy that came in 10 out of 10 pain, that's something that, maybe a cortisone shot or surgery would be something just to get him out of pain so he can move better. So long term, he can have the results from, physical therapy and chiropractic care that'll help him a little more long term. So again, myth number 4, that surgery is never needed. That's not always the case. There is a place. So the 5th and final myth of 5 myths of sciatica pain that you should know, or sciatica that you should know, is piriformis syndrome. This is my favorite to talk about because it just cracks me up how much we just throw out this term just as a kind of a cop-out term, in my opinion. So you'll hear a lot, hey, your piriformis is trapping your sciatica or your sciatic nerve and it's causing your sciatica, or your piriformis is too tight, or your glutes are too big, it's putting pressure on it. Do I think, a structure in the deep glutes could be compressing the sciatic nerve? Yeah, for sure. But I think it's overdiagnosed, especially based off the research and evidence. And there's not a strong or a strict diagnostic criteria for piriformis syndrome or deep gluteal syndrome, which is now kind of what more it's called. So again, a lot of times too, you always want to rule out the spine, and honestly, probably more plausibly, if you're having that posterior hip pain or that glute pain that going down the leg, a lot of times it's the diagnostic criteria for piriformis syndrome is actually very similar to a lumbar nerve root pathology. So that's a big thing, is you want to always rule out the spine first if you're a practitioner, and a lot of shoulder pain too does get referred from the neck. So always rule out the spine first to keep, and that's honestly probably, it's over 50% of the time coming from those areas. So we just want to avoid, just jumping right to, where the pain's at is where the problem's at. Because a lot of times it's not where it's at. Where the pain's at is not necessarily where the problem's at. So something to keep in mind. But again, I don't want to say that I never work on the glutes or piriformis, because that's never the problem. I weekly dry needle and do a lot of muscle work on the glutes and on the piriformis. So I'm never saying that's not the problem. I don't want to convey that I never work on those, because it's dumb, because I think that can be an issue sometimes, and it can just be a small part of the problem. So, okay, that is the 5th myth of the 5 myths. If you guys have any question, please let me know. Drop them below. I'll include all the studies that I used to kind of form my opinions on this and to help get me better information. So if you guys can take a read through those, and if you have any interest or questions on those, let me know. So thank you guys for watching.